My name is Dr. Nellie Tan, and I'm going to give a talk on PSMA PET MR. Should we be doing this? This was an invited plenary session that I gave at the 2019 SCPT MRI meeting in Colorado. Objectives of today's talk are to review the limitations of current imaging, specifically prostate MR, and then introduce you to PSMA as well as the role of PSMA in the setting of biochemical recurrence and staging. Prostate MRI has shifted the paradigm for how prostate cancer is diagnosed and subsequently treated. However, there are clear limitations to prostate MRI. Up to 20% of index lesions are missed by MRI. The inter-reader agreement is low for PIRATS 3 lesions and even for PIRATS 4 lesions in the transition zone. In addition, majority of metastatic lymph nodes in prostate cancer are sub-centimeter, which is subthreshold for conventional CT and MRI criteria, and thus PET can help reduce these gaps because it is a whole body imaging that's driven by molecular expression, not morphology or size. PSMA is one radiotracer that's used in prostate cancer imaging. PSMA is radioligands are small molecule inhibitors that bind to the active domain of the PSMA glycoprotein. There are several different types. The most common one is gallium-68 PSMA-11, and unlike antibodies, for example, prostacint, these small molecule inhibitors are internalized into the intracellular region, and thus there are high tumor to background contrast. The PSMA is expressed up to 1,000-fold in prostate cancer, which gives it the specificity as well as the sensitivity for detecting prostate cancer and subsequent metastases. Let's talk about biochemical recurrence first, because this is probably the most important role currently for PSMA PET CT, not necessarily PSMA PET MR. Biochemical recurrence occurs in almost half the men after radiotherapy or definitive prostatectomy. And CT and MRI are not sensitive because, again, most lymph node metastasis and recurrence are small, and so there's low sensitivity. We've shown in our research, performing a comparative meta-analysis, PSMA PET CT compared to fluciclovine PET CT, that PSMA has higher detection at very low, and PSA of 1 to 2 compared to fluciclovine. And for patients with post-treatment PSA of 1 to 2, there was a significant increased sensitivity of PSMA over fluciclovine. This was confirmed by a head-to-head trial that was published in Lancet Oncology in August 2019, which demonstrated both higher per lesion and per patient detection in a setting of biochemical recurrence with a post-treatment PSA of less than 2. The overall positivity rate on PET CT PSMA was over 50%. Lymph nodes were present in 30% of PSMA compared to 8% with fluciclovine PET CT, and metastasis were seen up to 16% in setting of biochemical recurrence compared to 0 in fluciclovine cohort in men with post-treatment PSA of less than 2. So PSMA PET CT is really good in the setting of biochemical recurrence, and at this point at least there's not clear evidence to suggest added value of PET MR in the setting of biochemical recurrence. Here's an example of a patient who had a prostatectomy and had a post-radical prostatectomy PSA of 0.2. And we see here on this PSMA PET CT that there's this 3 millimeter internal iliac lymph node that is positive on PSMA PET. This would not be called by CT or MRI. What about the role of possibly PET MR in staging? In staging, studies have demonstrated that the overall increased sensitivity per patient is increased by 10 to 20% with PET MR compared to MRI. This blue line demonstrates the area under the curve for MR, and we see that PET is increased in sensitivity or accuracy overall, but together the AUC improves. So there's added value of combining both MRI and PET for evaluating staging. Here's an example of a patient, 69-year-old man on active surveillance with low-grade Gleason 3+3 or group 3 biopsy-proven low-grade tumor, and patient had 2 negative MRI, here representative images of the negative MRI, and the patient subsequently underwent PSMA PET, and we see multifocal lesions, here the dominant one in the left transition zone, but an additional focus in the right peripheral gland. I would probably recommend a targeted biopsy in this region because we know that prostate MRI misses up to 20% of index lesions. So PSMA, we know, detects more index lesion and is very sensitive for identifying multifocal prostate cancer compared to MR. And thus, there is potential role of PET MR for evaluating men with possible prostate cancer, and so both to identify as well as to localize the number of prostate cancer foci. What about the role of PET MR in seminal vesicle invasion and extracapsular extension, so T3 disease? The literature suggests that there's an increased sensitivity by 10% for evaluating T3 disease, both extracapsular extension and seminal vesicle invasion. If you look at this, we see that across 4 readers, the sensitivity for extracapsular extension increases across all 4 readers, whereas specificity drops just a touch, but not significantly. In addition, a similar increase in sensitivity for seminal vesicle invasion is seen across all 4 readers, with a slight decrease in specificity. Here's an example of a man with Gleason 9, so aggressive prostate cancer, PSA of 27, and we see that on T2 images, the patient has widespread prostate cancer, and there is extension into the seminal vesicles that we see by DWI as well. So here we see a widespread prostate cancer extending into the seminal vesicles, but on PSMA PET, we see that the prostate cancer is pretty widespread, replacing the entire prostate, and the seminal vesicle invasion are a lot more obvious, especially on the left, compared to the MRI. Thus, PSMA PET MR may improve the diagnostic confidence for evaluating extracapsular extension as well as seminal vesicle invasion. What about for lymph node and bone metastasis? PET-CT, as we mentioned earlier in biochemical recurrence, is very good for evaluating lymph node metastases and bone mets after radical prostatectomy or definitive radiotherapy. This is similarly true for initial staging of prostate cancer. And there were studies that demonstrated that the lymph node metastases, the sensitivity increased by approximately 30% compared to MRI or even bone scan. And thus, there is potential role for PSMA PET-CT. It's unclear at this point if MRI adds any value for evaluating lymph node and small bone metastases for patients with suspicion for metastatic prostate cancer. Here's an example of a 65-year-old man with new diagnosis of Gleason 8 prostate cancer, and on the MRI we see a pretty obvious mass here in the right mid-peripheral gland with associated restricted diffusion, and this was a Pyrite 5 lesion. We see uptake on PSMA PET-CT. In addition, we actually see additional foci of prostate cancer on PET-CT. However, on PET-CT, we also see that there is this avid focus in the right iliac bone, which has made this patient staging M1, and this was not detected by MRI. So with PET-CT, we see more prostate cancer foci. In addition, we're able to detect small bone as well as lymph node metastases. There are several caveats for PSMA PET. Number one, up to 7% of prostate cancer foci will not have PSMA expression and thus will not have uptake. PSMA overdetects low-grade prostate cancer, so it's very sensitive for low-grade and intermediate and high-grade prostate cancer. And there is a role for MRI because MRI, we do not see low-grade prostate cancer to the same degree. Prostate cancer missed by PSMA are different from the prostate cancers missed by MRI. So there is a complementary role for PSMA and MR. Here's an example of a 69-year-old man with Gleason 7 prostate cancer, and we see this pretty obvious PIRADS 5 lesion in the right transition zone. And as we can see, there's no PSMA uptake. So this is one caveat of PSMA. Up to 7% of prostate cancers do not take up PSMA. They don't express PSMA. So in summary, PSMA is highly sensitive for all prostate cancer, which can be useful if local therapy such as HIFU is being considered. For biochemical recurrence, PET-CT is probably the best modality. At this point, it's unclear what the added value of MRI is. In staging, though, PET MR may play a complementary role for prostate cancer detection as well as evaluating T3 disease. For staging lymph node and bone as well as distant metastases, PSMA PET-CT is very effective, and there's insufficient evidence at this point, at least, for the added value of MR for PET MR. And my suspicion is that PSMA PET-CT will supplant current imaging to evaluate for lymph node as well as distant mets. The next step is really to determine what the cost is. PET MR is a lot more expensive than PET-CT, and at this point at least, it's unclear what the added cost for every prostate cancer detected is beyond what we can see by MR, and what is our willingness to pay for this increased sensitivity of prostate cancer by 10 to 20%. And right now it's unclear. So in conclusion, we're probably not ready for PET MR for screening prostate cancer or even initial evaluation in the setting of initial diagnosis. However, in challenging cases, PET MR can have a very complementary role to really identify these lesions that are missed by MRI in the setting of continued suspicion. However, in the setting of biochemical recurrence, PSMA PET-CT has a very important role and will probably supplant current imaging guidelines, including fluciclovine as the primary study of choice. Currently, PSMA is not FDA approved. This is a per institution basis because gallium-68 PSMA is open IP. However, as studies unfold, hopefully we will have wider availability of PSMA for patients.